So we will get to treatment, and that's the main idea, just show you a practical approach to patients with, I would say, non-alcoholic fatty liver disease, just because I'm so used to after 10 years doing research in this arena. But at some point I will have to get used to change it to MASLD. But I also, as I said, wanted to emphasize a little bit what's happening on these patients, why we need to treat them the way that I will suggest we treat them, okay? So there's hope, there are medications. So for all of those that when Dr. Gray started talking, got worried and didn't order dessert, I think we can still have good options. So nothing to disclose. And as I said, I divided it in four topics. We will talk about NAFLD as a systemic disease. We will talk briefly about extrahepatic implications of having a fatty liver. I will go very quickly, as Dr. Gray already addressed, cardiovascular risk factors, and then we will go to treatment. That's probably the part that you're more interested about, okay? So talking about pathophysiology, we need to understand what's happening when we are fasting and when we are in the postprandial state. So if you are fasting, you are living mainly on free fatty acids, okay? Your adipose tissue is breaking down triglycerides and releasing those free fatty acids so that your organs, liver, skeletal muscle, can use that energy. Because you need to save glucose for those organs that only depend on your glucose, and that's your brain and red blood cells mainly. So the liver is producing glucose in that fasting state to keep your blood sugars normal. Now when we eat, that gets sensed and you secrete insulin. And the first thing that happens when you secrete insulin, you shut down your adipose tissue. So you stop releasing those free fatty acids into circulation. And as insulin levels continue to go up, then you shut down your liver. And then you stop producing glucose, either by glycogenolysis or gluconeogenesis. And you are getting the glucose from your food. And the third thing that happens as insulin continues to increase in the postprandial state, you activate your muscle. So you translocate GLUT4 and your muscle is taking that glucose. So if you remember, I said when you are fasting, you are using those free fatty acids, but in this scenario, you are using glucose. And that's a metabolic switch that we all go through the day. We go from free fatty acids to glucose, and that's the normal thing. And it's one of the first things that gets impaired when we have this cardiometabolic disease. So because we don't eat as good, and because of that we have a lot of adipose tissue, or it could be that you are lean, but maybe your parents had type 2 diabetes. Maybe both your parents had insulin resistance and now you have insulin resistance. So although I'm using a obese drawing there, it could be that you just have bad genes and your adipose tissue is sick. And that's the main problem here. Your adipose tissue is sick and it doesn't stop releasing those free fatty acids into circulation. So whether you're eating or not eating, you have increased free fatty acids that start accumulating in all organs. So we are interested in the liver because the liver has an enormous capacity of absorbing fat. So 60-70% of your liver can be fat if you have a fatty liver. So it's easy to measure and it creates a lot of trouble. But if you have 2% of fat in your skeletal muscle, that's a problem in your skeletal muscle. If you have 1-2% in your heart, that's diastolic dysfunction. So if you have fat in your kidneys, that may make you more prone to hypertension. So this is a systemic disease where the adipose tissue is sick. And then as the organs start accumulating fat, they become insulin resistant. So your liver is shooting glucose where it shouldn't be, so you are prone to hyperglycemia. Your muscle cannot respond, cannot uptake that glucose, so your blood sugar tends to go up, so does your insulin levels. And insulin, although I'm saying this is insulin resistant state, that only works for your glucose because your fat or all the fat pathways are not, they don't become insulin resistant. So insulin, it's a lipogenic hormone, produces fat. So it's a positive feedback where that insulin that is trying to compensate for the high glucose keeps telling your liver you need to synthesize fat. And that's how we end up with these patients with fatty liver. So it is important to understand that we will be talking about how we can improve the liver, and that's because when you have NASH, you have increased liver-related mortality. But once you have only fat, and although we tend to think of this as a more benign condition in your liver, you already have increased cardiovascular mortality if you have fat in your liver. So fat in your liver, think of you are metabolically sick. And then if you have fibrosis or if you have NASH, that's a liver problem. But before, you already had problems. And this figure, Dr. Gray already mentioned it, but and she explained perfectly how liver-related mortality increases with overall mortality, especially when you transition from stage 1 to stage 2 fibrosis. But I want you to focus on what is there. That's the cardiovascular mortality, right? Which is the main reason for these patients to die. So we will. So how we approach patients that have a fatty liver. So, and the main thing is, okay, do they have NASH, or do I have a suspicion that they have clinically significant fibrosis or not? So we will start going to those that we don't think they just have that fat. But as I told you, these patients have increased cardiovascular mortality. So we need to do a big effort on controlling cardiovascular risk factors. We'll talk about what to do to try to reduce the weight, lifestyle intervention, pharmacology, drugs, or metabolic surgery, pharmacological treatments. And then we won't talk much about how to control other cardiovascular risk factors. Probably Dr. Gray already said everything that I could have said. I will just focus just slightly on lipids, because liver and dyslipidemia are the same thing in a way. Okay, I will explain to you that if you have a fatty liver, you have dyslipidemia. So the liver usually secretes VLDL, and that's an ApoB, a atherogenic particle, but it's usually rich in triglycerides, so it's not the worst particle that it's circulating in your body. But what it does is all these lipoproteins are bouncing to each other, exchanging cholesterol and exchanging triglycerides. So the VLDL is more triglyceride rich, and it pours triglycerides into the HDL and LDL, and it receives a little of cholesterol from those molecules. So when you have a fatty liver, and this is inhibited by insulin, so when you have a fatty liver, you have a lot of fat, so you have to put it somewhere, you accumulate some, but then you just secrete a lot of VLDL. So those particles are big and very rich on triglycerides, okay? So your VLDL levels, if we could measure, we did that, and I think I put a slide there where I'll show you, but you have a lot of VLDL and it's triglyceride rich. So when it starts bouncing and exchanging triglycerides and cholesterol, it gives a lot of triglycerides to the LDL and to the HDL. So you end up initially with very big particles rich of triglycerides, but triglycerides are easy to just get rid of, right? We have lipases in our endothelium, in the liver. So those triglycerides are used by your body, and as you remove all the triglycerides, they just got all the cholesterol out because they receive a lot of triglycerides. You end up with a very small LDL particle that is highly atherogenic, okay? Small and dense LDL, we will go back and I will mention something in the next slide about that, but then you end up with a very small HDL that is actually cleared by your kidney. So you end up with what we used to call years ago diabetic dyslipidemia. And now I can tell you, it's not diabetes the reason why we have it. It's because we have a fatty liver, it's high triglycerides, low HDL, and small and dense LDL. And that's one of the reasons why these patients are at increased cardiovascular risk, because that LDL is highly atherogenic. And the reason behind it is, if I could measure LDL in a normal subject, I have this amount of cholesterol. The LDL represents just the cholesterol in these particles, but you can see that you have bigger particles. So if you were to measure ApoB, you have a certain amount of ApoB. Now, if you do the same in a patient with fatty liver, when you measure the cholesterol, you have the same amount. But if you could measure ApoB, then you have more particles, and that's an expression of higher cardiovascular risk. So emphasizing the need to, for example, calculate non-HDL, which is just total cholesterol minus HDL, which would give you a better reflection of what's going on, because it gives you a reflection of how much ApoB there is there. So we published indeed a couple of years back where we show that the ratio of ApoB, that's the bad particles, ApoA1 is the good particle, is the HDL. That ratio is increased in patients with fatty liver. That was independent of the presence of obesity, independent of the presence of diabetes. And you can see how when we measure LDL, particle size, LDL was smaller. So as I explained you from a pathophysiologic standpoint, we saw it in our study. And moving on what to do with these patients, Dr. Gray already mentioned we can safely do statins. We showed that years ago, where we used a randomized control trial where we were assessing pioglitazone. So I want you to just focus on the placebo group. All patients that were not on statins, or most of them, were starting on a statin during the running phase. And we showed that not only it was safe, liver enzymes tended to go down, but then when we look at the histology in those patients, it didn't change. So overall, statins do not improve histology in fatty liver, but they are safe. You can give them if liver enzymes are elevated. Probably if they're above 200, you can think it twice, but other than that, you can probably safely use them. And none of the patients that were on statins had any elevation of liver enzymes. On the contrary, the ones that were not starting on statins were the ones that had higher peaks for liver enzymes. So use statins. I won't talk much about other lipid medications. I do have a particular interest in them, so if you have any questions on other drugs for dyslipidemia in patients with fatty liver, I'm happy to talk about that. So then I won't talk much about how to treat diabetes, but I want to emphasize that these patients are at increased cardiovascular risk. So if you have a fatty liver, you have diabetes, we want to emphasize those medications that improve cardiovascular outcomes. And that's GLP-1s. I just put liraglutide because it was the first one to come up with the study, but other than the leader study, semaglutide has shown similar results. SGLT2 inhibitors like EMPA-REG study and Farxiga afterwards, dapagliflozin, they showed improved cardiovascular outcomes. But I want you to remind you that in 2005, we already knew that pioglitazone, which is $5 per month, already showed cardiovascular benefit. Okay, that was 2005. And then again, when they did the IRIS study more recently, also improved cardiovascular outcomes. If you look at the numbers, SGLT2 inhibitors and GLP-1 is around 16% reduction. If I go back, 13 and 14, this was similar with the first pioglitazone study, but way better on the second one, where they were not targeting type 2 diabetes. Actually, all those patients did not have diabetes. They used a diabetic medication in patients with high insulin resistance, so probably a fatty liver. Okay? Moving on, we talk about this part. I didn't address lifestyle intervention yet, but then what Dr. Gray was mentioning, we need to screen. Once we have this idea that the patient may have NASH or clinically significant fibrosis, and that's what we are going now. Guidelines have moved to try to do fibrosis diagnosis. Then on top of that, we need to address NASH, okay? So we'll be talking in the last probably 15 minutes about pharmacological treatment. Here I put not all, but just a summary of some studies, because the typical question when we start talking about lifestyle intervention is which diet is best? What should we recommend patients? And these are studies that use MRS to try to see changes in liver fat before and after, and obviously it gives us just an idea of histological changes, but we cannot know exactly what's happening histologically. But you can see that regardless of the type of diet that you use, whether you compare very low fat, low or high carbohydrate diet, a balanced diet, low fat versus low carbohydrate. This is low carb, high fat versus intermittent fasting. That's fasting 2 days out of the 7 days of the week. Or if you do calorie restriction, just a hypocaloric diet versus time restricted. And that's eating only from 8 a.m. to 4 p.m. in that study. You can see that once you achieve a weight reduction, when that weight reduction is similar, the reduction in liver fat is pretty similar. And you can see, obviously, there are fluctuations. These are all different studies, different populations. But they align pretty good, where if you have this weight reduction, depending on how much you lose, that's how much liver fat you lose. So if we look at what happens with exercise alone, you can see that exercise by itself, and this is pretty consistent among studies, you don't have a lot of weight loss just with exercise, and that's because you're probably all very familiar with the idea, oh, I go to the gym and then I come back and I'm starving. So you eat twice. And your body is pretty good at trying to keep your balance pretty steady. So no weight loss when we do just exercise in most studies. So the reduction in liver fat is pretty low. We have this 30% liver fat reduction as a cutoff point in studies where we think there's histological improvement if you do more than 30%. That comes mainly from studies from other authors. In our case, in our hands, they don't correlate that well, but let's use that 30%. You can see that with exercise alone, you're most of the time far, unless you were able to achieve some weight reduction. When you combine both, you have more weight loss, you have more reduction on liver fat. So it seems that it's pretty consistent, that it doesn't matter what type of diet you use, it's how successful you are on achieving that weight loss. And that will depend on your patient, because I have patients that like intermittent fasting, I have patients that would hate it. I have patients that they rather just eat whatever they were eating, but just smaller portion sizes, and others that say, no, I want to feel full all the time, so they have to improve quality of the food. Moving on to histology, this is a large study that was done in Cuba, around 293 patients, where they just did lifestyle intervention, could be a combination of diet and exercise, but they look at how much weight they lost. Okay, and here they divided based on less than 5% of body weight, between 5 and 7, 7 to 10, and more than 10. So if you have less than 5, that's pretty much like response from a histological standpoint than placebo groups in clinical trials. So, but the big jump happens for steatosis and inflammation when you achieve more than 5%. So that's a target if you want to reduce liver fat. I usually tell patients more than 5%. But if you want to go further and improve resolution of NASH, you see that the big jump happens about 7% of weight loss. And then if you actually want to improve fibrosis, you can see that it's pretty flat until you get to over 10% of weight loss. And after that study, I think we all took those cutoff points, and they appear in guidelines where you say 5% for liver fat, 7 for inflammation and NASH, and ballooning and NASH, and then over 10 for fibrosis. So that's the weight loss that we need to achieve. Talking about metabolic surgery or bariatric surgery, this is a meta-analysis with several studies, over 2,500 pair biopsies. And after bariatric surgery, around 40% of the patients were able to regress fibrosis, okay? And we can see this as a good thing or a bad thing. So you can say, oh wow, 40% achieve a regression of fibrosis. So that means that 60% of the patients, despite significant weight loss, didn't achieve any regression in fibrosis score, which tells me in a way that fibrosis may be a point where it's maybe too hard to get improvements, and we may be needing to focus early on treating these patients. This is a more recent study with the bariatric surgery. It's a randomized controlled trial where, I don't know where this is pointed, but yeah, you guys can't see it. So they compare lifestyle intervention against two different types of bariatric surgery, Roux-en-Y versus sleeve gastrectomy. This is the amount of weight loss, so you can see around 30% with a Roux-en-Y. So humongous amounts of weight loss. And you can see resolution of NASH around 60%. Both types of surgery were similar, okay? And then if you look at fibrosis improvement, around 40%, similar to the meta-analysis that I showed you before. Again, despite a lot of weight loss in a range where with medication would be really hard to get, okay? Although we have better medications that can get to 20% weight loss reduction, and we will talk about that in a moment. Despite this amount of weight loss, we still only had regression of fibrosis in only around 40% of patients, meaning that 60% of those patients didn't improve. So until here, I kind of suggested that it's all a matter of weight, although at some point with fibrosis we may be too late. And this is a recent review where we tried to put all the lifestyle interventions and weight loss medications and bariatric surgery and compare the amount of weight loss and the amount of liver fat reduction. And you can see that it correlates pretty well. So I can say that weight loss, if you reduce it, then you will have a proportional reduction in liver fat, okay? So it does seem in that sense that it's all a matter of weight. However, it if we look at this is a large meta-analysis over 10 million patients from 93 studies, all assessing prevalence of fatty liver. They, after putting all those studies together, they calculated that 19% of all patients with fatty liver were lean, so normal BMI. Not only that, for those studies that had biopsies, they showed that those patients that are lean and can progress to more severe forms of the disease is not negligible. So 39% had NASH, 29 had clinically significant fibrosis, and there were even some patients with cirrhosis with normal weight. Suggesting that it's not only a matter of weight. If you're overweight and obese, you will get a proportional improvement as you come down on your weight. But this is a problem of the adipose tissue, where if you have a sick adipose tissue, then it can happen when you're lean. And usually because you have a family history of diabetes or something that increases your insulin resistance. PCOS would be the same thing. This is also a recent study with 36 patients that had advanced fibrosis when they went to have bariatric surgery. And they followed them for 6 years, and you can see that still 17 out of the 36 had advanced fibrosis after 6 years of bariatric surgery. And that's despite losing 23% of weight loss after 6 years. Suggesting that if you're at that point, improving fibrosis may be really hard. And I don't particularly agree with the concept that we need to wait until the disease is farther on to treat it, because we have tools available that we can use early on. So we don't have any drugs approved to treat NASH. So I will be talking about medications that can be used for other conditions that we better use them if patients have a fatty liver, and we'll be talking about new medications that are in the pipeline. So these are the ACE guidelines, and they are all very similar. So we will go through this one, and then I'll show you just small differences. But overall, if the patient has, and I'll show you the data on this. So, but basically, if the patient has type 2 diabetes, and you think they have liver disease, NASH, or clinically significant fibrosis, pioglitazone or GLP-1 receptor agonist. If the patient, and this is the ACE, is the only one that has this section, says if the patient has type 2 diabetes, they have a fatty liver, but no evidence that they have severe liver disease, then you can use any of these three, and those are the ones that have cardiovascular benefits, and also they all show to decrease liver fat. SGLT2s, there is good data with liver fat, that there is a reduction in liver fat, but it's not that impressive. But it does come down. And then if you don't have diabetes, but you have liver disease, they recommend vitamin E. We'll go over the data for that. And then if you have obesity, whether you have fatty liver or NASH, lifestyle, and that's kind of across the board. And then they recommend GLP-1s for obesity or overweight with metabolic risk factors or bariatric surgery. And then AASLD came out with guidelines which are very similar. They only mention semaglutide by name because it's the one with the largest randomized controlled trial with histology. So they didn't put just GLP-1 receptor agonist. And obviously semaglutide is more powerful than prior, like liraglutide, although there's a very small study with liraglutide that also showed to resolve NASH. Similar, vitamin E is mentioned in patients without diabetes, and again, this is similar, just the only difference is that they specifically mentioned semaglutide. And the ADA came, they presented this in the ADA meeting 2 days ago, pretty much the same as ACE. So they were presented by the same person that wrote ACE. So they tried to be pretty consistent. So they have a little bit of other recommendations, but for the purpose of this presentation, let's just go with PIO and GLP-1, pioglitazone, GLP-1 receptor agonist, if they have diabetes and NASH, maybe vitamin E if they don't have type 2 diabetes and NASH, and GLP-1s early on if the patient is overweight and or has obesity. So let's go over the data that just supported those guidelines. So this is just looking at resolution of NASH. I get this question often, well, metformin helps for fatty liver. It doesn't. It was until recently considered first-line therapy for type 2 diabetes. Now you could potentially use other medications. I still consider it a first-line therapy. We have data since 1973 that it's safe. So I do use it as first line. it's cheap, almost free at Publix. So, but it doesn't help for fatty liver, so we don't use it for that purpose. We just use it for type 2 diabetes. Pioglitazone has different randomized controlled trials. That's one we did. We published 2016. I think we finished it like 2013. Took us a little bit, but good resolution of NASH compared to placebo. Liraglutide, the same. That's a small study, but shows significant resolution of NASH, and that was further confirmed with semaglutide with more weight loss. Further, this is a daily dose. It's not commercially available, but this is pretty much like the 2.4. That's how they designed the study, trying to do a daily dose that would coincide with a 2.4 weekly dose, but good resolution of NASH. Vitamin E, the PIVEN study in 2010 showed good resolution of NASH in patients without diabetes. We redid that study in patients with diabetes, and while the absolute numbers were very similar, ours was a smaller study, only 68 patients. If you compare vitamin E to placebo, there was a third arm that I'm not putting here. The P was 0.04, but we were shooting for 0.025 because there were 3 arms. So it came out as a negative study, but in absolute terms, it's pretty much the same as PIVEN's, but the guideline says in patients without type 2 diabetes because our study was technically negative. But I do personally think that it probably works, it's just that we don't have the data. I wanted to put out there the SGLT2 study. I don't think this is a great study, but it was unfair if I didn't put it here. It's open label. I'm not sure exactly. They had a great resolution of NASH in those 20 patients. It was not statistically significant. Probably more data will be coming on SGLT2s in histology, changes in histology, but we will have to wait a little bit until we can do further recommendations. But guidelines tell us that we need to screen for fibrosis. So how are we doing at regressing fibrosis with these medications? You can see that we are doing pretty badly. So pioglitazone, our study was negative. There was a trend, and if we look at this as reduction in the mean score of fibrosis, it was significant, but overall, that's not a huge difference, 13% difference. That means that if I give pioglitazone to 100 patients, maybe 13 will improve fibrosis. So not a huge effect. Liraglutide was negative. Semaglutide was pretty negative. They claim that the placebo response was pretty high, but it's similar to several other studies. And when they came with the semaglutide study in cirrhosis, it was also negative for improvements in fibrosis. So I think overall, if you are way down the line of fibrosis, it's really hard to come back. And vitamin E, also a trend, but again, a 20% difference. So not very good on fibrosis improvement. So, however, we are able to delay the progression of fibrosis. Both the study with semaglutide, our study with pioglitazone, they both showed that we can delay the progression of fibrosis. So, for me, it doesn't make a lot of sense to say, let's screen for fibrosis to give you a medication that will not do anything for fibrosis if we have medications that will delay the progression. So the guidelines are out there. It's a good step because NAFLD was completely out of the map, right? So in the last 20 years, we've come a long way, and now we have guidelines, and people are talking about this, and that's important. But we also need to remember that we don't have great medications to improve fibrosis, but we do have medications that delay the progression. This is a meta-analysis with all pioglitazone papers, and there is an effect on fibrosis, but that's just putting all the studies together and doing just the patients with advanced fibrosis. So there may be a potential for pioglitazone improvement in fibrosis. Again, the strength of the effect may not be all we want it to be. I wanted to bring some things new, some that you are brand new. So this is not that new. This is Therapeutic, it's already published. It's a dual agonist. GIP, GLP-1, more weight loss. It's Mounjaro. It's available for patients with diabetes, still not for obesity, but you have pretty significant weight loss reductions, and this is just looking at liver fat. And you can see significant decrease of liver fat. We still don't have any data on histology, and it was not compared against placebo, but against insulin. So it did pretty good on that study. We have to wait for histology. This was presented yesterday. This is a triple agonist. So GIP, GLP-1, and now it adds glucagon. GIP and GLP-1 don't have receptors in the liver, so it's all through weight loss, we think. But glucagon has many receptors, so the liver is very sensitive to glucagon, and it produces beta oxidation. You burn fat. So the reductions in liver fat seen in this study are, as far as I remember, larger than any other medication or study. It's 80% reduction of liver fat. I don't remember the percentages, I took a picture so I may have it, but resolution of MASLD, which is kind of a new term. So bringing the liver fat to less than 5% was like 60%. So the impressive results in liver fat. We still don't know. The medication seemed pretty safe in that study. They had a little bit of an increased heart rate, which is common in GLP-1 receptor agonist and in the dual agonist as well. But it was a relatively small group of patients, and they had one cardiac arrhythmia. They didn't go into details on what exactly happened, so we'll have to see. But impressive results on liver fat with this medication. It's retatrutide. I was talking with somebody earlier and said this is a hard pronunciation, so I don't know who comes up with the names, but that will definitely give me trouble when I'm giving lectures. So now talking a bit, and I will be brief on these, just medications that are in the pipeline. So, well, that was on the pipeline because obeticholic acid is out for NASH. I don't know if you get the Medscape news, but you probably got like a medication rejected by the FDA for a second time. That's obeticholic acid. It increased LDL, it produced drug-induced liver injury. So FDA reviewed it, said no. So we won't have obeticholic acid. This was a large study showing some improvement in fibrosis, but it's 11% with the highest dose. And on top of that, you put the increased LDL, pruritus, and some patients with DILI. So we can kind of forget about that. Resmetirom is completed a phase 3 study, and that's a medication that it's a thyroid mimetic, but very specific for the liver. It reduces cholesterol, triglycerides, and in this study, improved fibrosis. Again, when you look at the numbers, it's just 12% compared to placebo. That means only 12 out of 100 will have benefit in the fibrosis. But important reductions in resolution of NASH and important reductions in liver fat. So we will have to see, again, new drug, new mechanism for all of us. So we are learning as we go. This was a large study. They didn't see major things, a little bit of the GI things, nausea, diarrhea, but nothing serious. So we will have, there's another side effect that they usually quote now, it's escaping my mind. Well, Lanifibranor, that was a large study, but not as large, so it was a phase 2, 247 patients. Lanifibranor is a PPAR, a pan-PPAR agonist, so it's, for me, it's like a pioglitazone plus. It has the alpha and gamma that pioglitazone has, and it has a delta, which we don't know what it does exactly, and results for me are very similar in absolute terms compared to pioglitazone. But improvement in fibrosis, which makes sense with the data that I show you for pioglitazone. So it's exciting having a new drug showing these large randomized controlled trials that nobody wants to fund for old medications like pioglitazone. But exciting times for that drug too, because it's moving along pretty well. And there's also an FGF21, which is a master regulator of lipid and glucose metabolism, efruxifermin, also showing improvement in fibrosis in a relatively small study. And there are other FGF21 agonists as well, so in doing research. So I think exciting times for sure in the NAFLD arena, but we already have medications that we can use. So to finish in the last 2 minutes, how do I see that we should be thinking when we are in front of the patients? So guidelines tell us that we need to screen in patients at risk. So when we do that, does the patient has, do I suspect the patient has NASH or clinically significant fibrosis? If I think it's a no, then it will matter to me whether he has if the patient is overweight or obese. I would go for GLP-1 receptor agonist or dual when they are available for obesity. If the patient has type 2 diabetes, we said GLP-1 or dual receptor agonist, SGLT2 inhibitors, or pioglitazone. And those are medications that are approved for type 2 diabetes. So I know I can improve the fatty liver, and I'm also improving their cardiovascular outcomes. Now, if the patients do have NASH or clinically significant fibrosis, the way I think of it is, does he have diabetes? And then I prioritize, and this is in accordance with the guidelines, GLP-1 agonist and pioglitazone. I usually start GLP-1 first, so that they start losing weight, and then I add pioglitazone so that they don't see any weight gain and tell me I don't want to be on pioglitazone. So you have to choose patients wisely, because it does have side effects, both those medications. One is the GI for GLP-1s. If they are good in the GI arena, usually very well tolerated. So kind of a first line therapy in this case. Pioglitazone, it's a little bit more troublesome. You just need to make sure, I always think of two things. Is the patient at increased risk of fractures, because it does increase your risk of fracture, and then does the patient has heart failure, and then it would be contraindicated. Other than that, we can discuss about other side effects that were reported, but none of them affects how I think of pioglitazone. And then if the patient don't have diabetes, then these medications are not approved. So, but I still have indication for overweight and obesity. So if that's the case, I can still go for GLP-1s. It's harder to get it approved through the insurance, but if you are persistent, many times you can get it. Now, if they don't have diabetes and they don't have overweight or obesity, we said, well, we don't have any drug that is approved for NASH, but vitamin E is over the counter. There is a meta-analysis in 2005 showing higher mortality with the use of high doses of vitamin E. That has not been in newer studies has not been observed, but it's out there. And it may increase a little bit the risk of bleeding, so be careful if the patient is already on anticoagulants. And then you could consider pioglitazone off-label. You do have data, but it would be off-label and at your own risk, let's just say that. So, but there's plenty of randomized controlled trials in patients without diabetes. So it does improve cardiovascular outcomes, like the IRIS study, and it does improve your fatty liver, like our study and the PIRS. But at some point, we will go to combinations, right? The way we treat type 2 diabetes, the way we treat hypertension, fatty liver is yet another metabolic disease where one drug will not cut it. Most likely, we'll have one drug, and then patients may still have problems. We will have to add another one, and so forth. And these are just good combinations, because pioglitazone and GLP-1s, you can prevent that weight gain from pioglitazone. Pioglitazone and SGLT2 inhibitors, you can prevent the weight gain and also the fluid retention that pioglitazone does. Because the SGLT2 inhibitor helps with heart failure. And with that, I will stop. Conclusions are pretty straightforward. I do think we have tools available, but we probably need to start diagnosing early and treating early. So again, I think the guidelines were a good step in the right direction, but I think at some point we will move a little bit. And we are, because we are already treating overweight and obesity, right? We have these medications available. So it's not that we are not doing it. We just do it for overweight and obesity. We don't say it's for fatty liver. And combination therapy, I think it's probably the way we will end up going. And with that, I'll stop, and I let you enjoy your dessert, and I'm happy to answer any questions.
Yes.